Welcome to the deep dive. This is where we take source material like articles, research, maybe even revision notes, and really boil it down to what matters most.
Exactly. The idea is to give you the key insights, make the complex stuff a bit more accessible.
And today we're diving into something very common, actually, but often carries a lot of, well, emotional weight. We're using revision notes as our source to look at nocturnal enuresis.
Or, as most people know it, bedwetting. Yeah.
Right. So the plan for this deep dive is to unpack these specific notes, pull out the high-yield info, perfect for if you're revising this or just want to get your head around it properly.
It's a really common topic for exams and just good general knowledge in healthcare, too.
Okay, so we'll basically follow the structure in these notes. We'll cover the definition, what causes it, the risk factors, sort of the mechanics of how it happens.
The pathophysiology, then what else it might be, the differentials.
Exactly. Then how common it is, who gets it, what it looks like clinically, how it's investigated.
And importantly, how it's managed, the likely outcome prognosis, and any complications. It's all laid out here.
Great, let's jump straight in then. Definition. How do these notes actually define nocturnal enuresis?
Well, at its core, it's involuntary urination, passing urine during sleep. But the key thing is, it's happening at an age when you'd normally expect a child to have bladder control.
And there are specific ages mentioned for that expectation, right?
Yes. The notes say it's considered normal up to age 5, still pretty common up to age 10, actually.
Okay.
And most children, they usually manage to stay dry both day and night by the time they're 3 or 4 years old.
Got it. So, involuntary wetting during sleep, with age being the crucial context. The notes also make a really key distinction early on, don't they? Primary versus secondary.
Oh, absolutely vital. Primary nocturnal enuresis means the child has, well, never really been consistently dry at night. They've always had periods of wetting the bed.
Okay, never consistently dry.
Whereas secondary means they were dry. They had a good period, at least 6 months, the notes specify, of being consistently dry at night, and then the bedwetting started up again.
Right. Primary never dry, secondary was dry, now isn't. That secondary type immediately makes you think, okay, what changed? What's the trigger?
Exactly. And even in the definition part, the notes flag up some initial contributing factors to keep in mind.
Oh, yeah, like what?
Things like problems with waking up, arousal from sleep in response to the bladder signals. Also, issues with the bladder itself, maybe capacity or making too much urine specifically at night.
Okay.
And interestingly, they specifically mentioned constipation right there as well.
Constipation again. That seems, well, not the most obvious link at first glance.
Yeah.
Do the notes explain that connection?
Not in huge detail right there, but it's a known factor. The thinking is basically that a full rectum, with lots of stool, can physically press on the bladder.
Ah, I see.
Yeah, reducing how much it can hold comfortably and maybe even irritating it a bit. It comes up surprisingly often.
Fascinating. Okay, so that covers the what. Let's move to the why, the etiology, the causes. The notes say the exact cause isn't totally clear, but it's usually a mix of things.
That's right. It's generally seen as multifactorial. They list things like a delay in the maturation of that bladder-brain connection. The communication isn't quite there yet during sleep.
Okay, so the wiring isn't fully developed yet.
Sort of. Then there's making too much urine overnight, increased nocturnal urine production. Genetics plays a big part too. It definitely runs in families.
Right, the family history link.
Yeah, and we already mentioned difficulty waking up to the bladder signals. And sometimes emotional factors can play a role, contributing to it or making it worse.
So rarely just one thing causing it, more like a combination. That makes sense. Which leads nicely into risk factors. What makes it more likely for a child to experience bedwetting, according to these notes?
Well, the big one is definitely family history. If a parent especially had issues with bedwetting, the child's risk goes up significantly.
Okay, genetics is key.
Yep. Gender is another one, initially anyway. The notes say boys are more commonly affected than girls, particularly in the younger years.
Right.
And there's constipation, again, listed as a clear risk factor. Stress and emotional factors are also highlighted.
So family history, being a boy initially, constipation, stress. Those are the main ones.
Those seem to be the core ones listed, but they add a few others too. Things like daytime incontinence, wetting during the day can be linked. Also sleep apnea, obesity, developmental delay in general, any underlying neurological issues, and sort of broader psychosocial stressors in the child's life.
It paints a picture of it sometimes being part of a wider set of challenges.
Okay.
Let's get into the mechanics, pathophysiology.
Huh.
How does the body actually do this during sleep? What are the mechanisms mentioned?
The notes break it down into a few key mechanisms. One is simply that inability to wake up. The brain just doesn't respond properly to the bladder's "I'm full" signal during sleep.
The alarm doesn't go off, essentially.
Pretty much. Another factor is reduced functional bladder capacity. This means the bladder, for various reasons, just can't hold the amount of urine that's being produced overnight without leaking.
Either the signal's ignored or the tank fills up too fast or is too small.
Exactly. They also mention an overactive bladder, where the bladder muscle itself is a bit twitchy, contracting involuntarily and causing leakage, even if it's not totally full.
Okay.
And finally, that increased nighttime urine production we talked about. Sometimes the kidneys just produce an excessive amount of urine during sleep, overwhelming even a normal bladder's capacity or the child's ability to hold on.
Right. Those are the ways it can physically happen. Now, a really crucial step in clinical practice is thinking, okay, it looks like bedwetting, but what else could it be? What do the notes list as differential diagnoses?
Yeah, this is super important. While most cases, especially primary, are just that, you have to rule out other things. The main differentials mentioned are urinary tract infection, a UTI.
Always high on the list with urinary symptoms?
Definitely. Then diabetes mellitus type 1, usually, in kids presenting like this. Also, diabetes insipidus, which is different, related to water balance and producing large amounts of dilute urine.
Okay, so infection, sugar diabetes, water diabetes.
Also, structural abnormalities of the urinary tract itself, problems with the plumbing, so to speak, and sometimes other primary sleep disorders might present with wetting.
Got it. So infection, metabolic issues, physical structure, or sleep itself. It really highlights why you need a proper assessment, doesn't it? Can't just assume.
Absolutely. You need to be sure of the diagnosis before you start treatment.
So let's talk numbers epidemiology. How common is this? And who does it affect based on the UK data in these notes?
It's surprisingly common, especially when they're young. The notes say about 15 to 20% of 5-year-olds experience it.
Wow, that's like 1 in 5 or 6 kids.
Yeah, but it drops off quite sharply. By age 7, it's down to about 5 to 10%. And by the time they're adolescents, say 15 plus, it's only about 1 to 2%.
That's a massive decrease. Really shows that most kids do just grow out of it.
It really does. And remember that gender difference we mentioned? Boys being more affected initially, maybe around 2 to 1.
Yeah.
The notes say that difference actually disappears after age 10. So in adolescence and adulthood, it affects males and females pretty much equally.
Interesting. And it can persist into adulthood?
It can, yes, but for a much smaller group. The notes give a range of about 0.5% up to maybe 2% of adults might still experience it.
So, very common young, drops off steeply, starts more in boys but evens out, and only a tiny fraction persists long-term. That's a clear picture.
Gives you a good sense of the natural course, yeah.
Okay, clinical presentation. What does it actually look like when a child presents, beyond the obvious wet bed? And how should clinicians assess it according to these notes?
Well, the core feature is obviously the recurrent wetting during sleep. A key point the notes make is that the child usually doesn't wake up during the event. They're often completely unaware until they wake up in the morning and find the bed is wet.
And it's not just a physical thing, is it? There's an emotional side.
Definitely. The notes are quite explicit about the potential emotional impact, feelings of embarrassment, maybe guilt, sometimes shame. That's a really crucial part of the presentation to be aware of.
So when assessing this, the notes seem to suggest a very structured approach based on the history.
Yes, very much so. And the absolute first step, the crucial fork in the road, is figuring out, is this primary or secondary enuresis? Did they have that 6-month dry period or not?
Right. So if it's primary, they've never really been dry. What questions are key then?
For primary, the notes recommend asking about the details of the wetting. How often does it happen? Is it every night, a few nights a week? When does it happen early in the night, towards morning? Roughly how much urine? Is it a small patch or a flood?
Okay, a pattern.
Exactly. Also, daytime toilet habits are important. Any urgency or frequency then? Is constipation an issue? What are their fluid drinking patterns like, especially in the evening? Do they have easy access to a toilet at night? And importantly, they suggest exploring other potential issues. Any developmental concerns, attention problems like ADHD, learning difficulties, behavior issues, emotional stuff. And finding out why the family is seeking help now. Is there a school trip, a sleepover, or have they just reached a point where they want to address it?
That's a thorough checklist for primary. What about secondary enuresis assessment?
With secondary, the focus shifts, doesn't it? You're looking for the cause of the relapse. So you need to pinpoint the onset. When did it start again? How long has it been going on? Were there any specific triggers around that time?
Like stress or changes at home?
Could be, yeah. The notes explicitly say to investigate the pattern and reconsider those differential diagnoses. Could it be constipation creeping in? A UTI? Is there any chance of diabetes? New behavioral or emotional issues. And sadly, they also include considering child maltreatment as a potential, though rarer, cause of secondary enuresis.
That's a really serious point to keep in mind. The notes also mention asking the child themselves.
Yes, definitely, especially as they get older. Does the child see it as a problem? What are their thoughts or worries about it? Getting their perspective is important. So yeah, framing it primary versus secondary is key for assessment.
Okay, assessment done.
Mm-hmm.
What about investigations? What tests do the notes recommend?
Well, the standard initial things are that detailed history we just discussed and a physical examination checking their general health, growth, looking for any physical clues like checking the spine or abdomen.
And urine tests.
Yes, urinalysis is mentioned, mainly to look for signs of a UTI or other things like glucose suggesting diabetes. Avoiding diary is also highlighted as really useful.
Right, tracking intake and output.
Yeah, recording drinks when they go to the toilet and tracking the wet versus dry nights gives you a baseline and helps see patterns.
And there's a specific point about when to do the urinalysis, isn't there? It's not always needed.
That's a really good high-yield point from these notes, actually. They clarify urinalysis is specifically recommended if there are red flags, like if the wetting started recently, suggesting secondary, if they also have daytime symptoms, or if the history or exam makes you suspicious of an infection or diabetes.
But not necessarily for every straightforward primary case.
Exactly. The notes suggest it's generally not needed routinely for uncomplicated primary nocturnal enuresis without any other worrying features. Saves unnecessary tests.
Good clinical practice point. What about fancier tests like urodynamics or ultrasound?
They're mentioned, but typically reserved for more complex cases. If you're worried about how the bladder is actually functioning, or you suspect a physical structural problem with the urinary tract based on the initial assessment, then yes, those might be considered, but not standard for most kids.
Okay, so history, exam, diary, targeted urine test, maybe more if needed. That logically leads us to management. How do these notes suggest tackling treatment?
It's definitely presented as a step-by-step, multifaceted approach, starting with the simple supportive stuff first. Like what?
Things like just talking openly about it, reassuring the child and family that it's common and not their fault. Maintaining a positive, non-blaming attitude is crucial. Then practical things. Regular toilet trips during the day, especially before bed. Making sure they drink enough during the day.
Enough, not less.
Yeah, enough during the day to encourage good bladder habits, but maybe tailing off liquids a bit in the couple of hours before bed. Avoiding drinks known to irritate the bladder, like fizzy drinks or caffeine. And again, actively managing any constipation.
Right, constipation keeps coming up.
It does. Simple behavioral things, too, like reward charts for dry nights or helping with changing sheets without fuss focusing on positive engagement.
And does the approach change much with age?
Yes, the notes make that distinction. For kids under 5, it's generally more of an expectant approach. Focus on those supportive measures, maybe trying without nappies at night if they're dry by day, encouraging toilet use if they happen to wake up. Basically, reassurance and simple strategies while waiting for them to mature.
Okay, watchful waiting for the little ones. Pretty much. But for children over 5, while reassurance is still vital, the notes suggest a more active management plan is usually considered if the basic measures aren't enough after a while. The regular toileting and fluid advice still apply, though.
So when active treatment is needed for the over 5s, what are the first-line options according to these notes?
2 main ones stand out.
Okay.
Alarm training and the medication desmopressin.
Okay, tell me about the alarms first.
So the enuresis alarm involves a sensor, usually a pad in the pajamas or on the bed, that detects moisture. As soon as wetting starts, it triggers an alarm sound, vibration, or both to wake the child up.
How does that help?
The idea is it conditions the child over time. They start to associate the feeling of a full bladder with waking up, eventually learning to wake up before they wet the bed, or even to hold on through the night. The notes say it's got a high success rate long-term and is considered the most effective strategy for sustained dryness.
Wait, it trains the brain-bladder connection. How long does it take?
You need to give it a fair go, Usually assess the response after about 4 weeks of consistent use. Families can often borrow them from clinics or buy them.
Okay, alarms for conditioning. What about desmopressin?
Desmopressin is different. It's a synthetic version of a natural hormone, vasopressin. Its main job here is to reduce the amount of urine the kidneys produce overnight.
So less urine being made while they sleep.
Exactly. The note suggests it's often offered first line when you need quick results, maybe for a school trip or sleepover, or if alarms just aren't suitable or the family prefers not to use one. It usually comes as a tablet you swallow or one that melts under the tongue.
Any catches with desmopressin?
The big one mentioned is fluid restriction. Because it makes you retain water, it's really important the child doesn't drink excessive fluids, especially around the time they take the tablet and overnight, to avoid a potentially serious side effect called hyponatremia. That needs careful explanation.
Right, crucial safety point. So alarms or desmopressin first line. What if those don't work or aren't suitable? Are there other options?
Yes, for more resistant cases, the notes mention using tricyclic antidepressants, specifically naming imipramine. But they add a strong caution about potential side effects, meaning it's generally reserved for specialists and used carefully.
Okay, a second or third line option.
Right. And sometimes combination therapy is used, maybe desmopressin, together with another type of drug called an anticholinergic, which can help relax an overactive bladder if that's part of the problem.
And when should they be referred on to specialists?
The notes give pretty clear criteria. Referral to a specialist enuresis clinic might be for help with starting alarm treatment, as they often provide the alarms and support. Or if the child hasn't responded to the first-line treatments tried by the GP.
Okay.
Referral to secondary care, like a hospital pediatrician, is more for cases with severe daytime symptoms alongside the night wetting. If investigations show abnormalities, if there's suspicion of underlying physical or neurological problems or other complex medical conditions.
Makes sense. And what about things like hypnosis or acupuncture? Do the notes mention those?
They do list them briefly: hypnosis, acupuncture, herbal remedies, psychotherapy, chiropractic treatment under complementary or alternative options. However, they explicitly state that the current evidence for their effectiveness in treating enuresis is limited.
Okay, good to know. So the management ladder is clear. Start simple, move to alarms or desmopressin, consider other meds or combinations if needed, and refer based on specific criteria. And always tailor by age.
That's a good summary of the approach outlined.
Right, nearly there. Prognosis, what's the likely outcome? What do the notes say?
Well, the overall message is quite positive, echoing those epidemiology numbers. Many children just naturally grow out of it as they get older, even without any specific treatment.
That's reassuring for parents.
Definitely. The notes state that most children, unless they have significant underlying neurological issues, will eventually become dry at night.
And they give a rate for that spontaneous improvement.
Yes, for primary enuresis without daytime symptoms, they quote an annual spontaneous resolution rate of around 5 to 10%. So each year, a decent chunk get better on their own.
Are there factors that suggest it might take longer to resolve?
Yes, the notes mention a few things that can predict slower resolution. A strong family history again, the presence of coexisting behavioral issues or developmental delay. And gender boys tend to take a bit longer than girls to achieve dryness spontaneously.
And that small group who continue into adulthood.
Yeah, the notes repeat that figure of around 1% persisting into adulthood, and this is often linked to cases that were more severe or complex during childhood.
But the notes also stress something important about the impact, even if the physical outcome is good for most.
Absolutely. They really hammer home the point that persistent bedwetting can significantly dent a child's self-esteem and emotional well-being, which is why managing it is important, not just waiting it out indefinitely for everyone. It also mentions that the more severe cases are the ones more likely to persist.
Which leads perfectly into the final section, complications. What potential problems are listed?
This is where the notes draw a really interesting distinction. They state quite clearly that severe physical complications directly from the enuresis itself are generally not a major feature.
Okay, so it's not physically dangerous in itself, usually. But the other complications sound pretty impactful.
They really are, and they're almost entirely psychosocial. Low self-esteem, embarrassment, sleep disruption for the child and family, these are highlighted as key consequences.
And worse for older kids.
Yes, for older children and adolescents, it can lead to real distress, social isolation, maybe being bullied, avoiding things like sleepovers or school trips that others take for granted. It can really affect their social development.
That sounds tough. What about adults who still experience it?
The notes mention that persistence into adulthood can cause significant psychosocial problems, impacting self-image, relationships, even career paths sometimes. So that contrast is stark. Minimal physical risk, but potentially major emotional and social consequences.
It really drives home why it needs to be taken seriously, even if it's common.
Yeah. Exactly. And the notes don't just focus on the child. They mention the family impact, too. The practical stuff, like constant laundry, the cost of pull-ups or bedding protection, the stress it can cause parents. And sadly, they also mention the potential, in some situations, for it to lead to frustration resulting in punishment or even maltreatment of the child.
Gosh, that's a sobering point. It really underlines the need for understanding, support, and appropriate management, doesn't it?
Hmm.
Especially linking back to that active versus expectant management, depending on age and impact.
Definitely. The psychosocial burden is probably the most significant complication discussed in these notes.
Well, that feels like a really comprehensive run-through of these nocturnal enuresis revision notes. We've covered the definition, the causes, risks, the how, the what else, the who and how common, assessment, management, outcome, and those really important complications.
Yeah, hopefully breaking it down like that, following the structure of the notes, makes that key information stick. That was the aim high-yield revision.
I think we definitely hit that.
Mm.
And reflecting on everything, particularly that heavy psychosocial impact we just discussed,
Mm.
here's something to maybe mull over. Given how common bedwetting is, yet how much shame or secrecy can surround it, how much potential is there just in simple awareness and open conversation between families, doctors, even schools to reduce that stigma and make sure kids feel supported, not embarrassed.
That's a really important point to consider, absolutely.
Thank you for joining us for this deep dive.
My pleasure.
And if you found this useful, particularly if you're revising for exams like the MSRA, you should definitely check out pastthemsra.com. They've got loads of great resources like the kind of notes we base this on today.
And do forget, freemsra.com, they offer some fantastic free resources as well. A great place to start.
That's pastthemsra.com and freemsra.com. Thanks for listening, and we'll catch you on the next deep dive.